Good evening, everyone. My name is Simiran Choudhary. On behalf of Voice of Healthcare, I warmly welcome you all to the panel discussion Breathe Easy, Prioritizing Lung Health for All, organized by Voice of Healthcare and supported by Pfizer. As we have all gathered here during the Lung Cancer Awareness Month, this event is more than a moment of observance. It is a call to action, deepen our understanding of lung cancer, and to push for progress in prevention, early detection, and treatment. Lung cancer remains one of the leading causes of cancer related deaths, accounting for nearly 1.8 million lives lost globally each year. Beyond the statistics, the conversation is about lives and stories behind those numbers and the impact we can make together. Today, we will explore recent advances in lung health and treatment innovation, the critical importance of early diagnosis, and the environmental and lifestyle factors impacting lung health. This discussion is dedicated to fostering a broader understanding of a stronger commitment to lung health with the hope of inspiring communities to prioritize respiratory wellness and take proactive steps for change. And today we are honored to be joined by a panel of distinguished experts who will bring in valuable insights into lung awareness and care. So let's together work towards a future where everyone can truly breathe easy. Now, I would like to introduce the panelists for the discussion. Dr. Tonse, consultant medical oncologist at Asian Cancer Institute, Mumbai. Welcome to our show, ma'am.
Thank you, Simran. Thanks for the warm welcome. I'm very glad to be here, a platform organized by Pfizer to create awareness about lung cancer to the general public and how we can make life better and prevent diseases and one of the diseases which are very lethal when diagnosed.
Thank you so much, ma'am, and thank you so much for coming to our platform. Dr. Tushar Patil, consultant medical oncologist at Sahyadri Hospital. Welcome to our show, Dr. Tushar. So, you're on mute, if you can unmute.
Good evening. Thank you, Pfizer. Thank you, the organizers, for giving us this platform. I think awareness, prevention are core to what we teach to our patients and their caregivers, and that should be the way the cancer would become little less burdensome to the entire society. So I think it's a great move that Pfizer has organized this kind of a session. Yeah, thank you.
Thank you so much, sir. Dr. Kapil Goyal, consultant medical oncologist at Rajiv Gandhi Cancer Institute of Research. Thank you so much, sir, for coming to our platform.
Thank you so much for the warm welcome. As we know that now focus is more on the prevention rather than cure. So general public awareness is very, very important, not just for lung cancer, for all other cancers also. So I'm glad to be part of this panel discussion and hopefully we can educate public about cancer.
Thank you so much, Dr. Kapil, for coming to our platform. And that's what our aim is, to create the awareness about lung cancer and the general awareness around it so that we can educate our public as much as we can. So thank you so much for being part with us for this cause. Starting with Dr. Tonse, ma'am, could you explain what exactly is lung cancer and the different types of lung cancer and how do they differ in terms of progression and treatment?
Hi, so lung cancer is a disease cancer which begins in the lung alveoli. So the lung has a subunit called alveoli, which are the soft spongy units where the gas exchange takes place actually. So whenever there is any abnormality, excessive growth causing multiplication of the cells, which becomes tumorous and later on spreads to the lymph nodes and the bloodstream, it is called as carcinoma, lung cancer. So there are widely two different types of lung cancer: non-small cell lung cancer and small cell lung cancer. So small cell lung cancer is virtually 99% of the times we have seen that it is due to smoking. So the non-small cell lung cancer is of different kinds. Commonest of them is adenocarcinoma lung, followed by squamous carcinoma lung and large cell carcinoma. So most of the lung cancers what we see in our clinical practice is due to smoking, even the non-small cell lung cancer variety. But in adenocarcinoma lung, there are certain types which are due to something called as mutational driver mutation associated lung cancer. So these are generally seen in non-smokers, females, and the Southeast Asian ethnicity. So, in somebody who's non-smoker, either active smoking or not, or passive smoking, and who has a presentation of adenocarcinoma lung, we do certain mutation analysis on the tumor or the blood to look at any mutation, which will say that this mutation is driving the cancer, and we have medications available for it. So these are the common types.
Thank you so much, ma'am, for explaining that to us and to all our audience. Moving on to my next question to Dr. Tushar. So, how does lung cancer develop at the cellular level and what factors influence its growth and spread?
So I think any cancer, there is a pathogenesis, or the way it behaves or forms is by means of chronic inflammation. So there are cells which are formed in the body. There are abnormal cells which are formed in the body. Each time an abnormal cell is formed, our immunity, our immune system cells identify those and try killing those cells. The moment this function is hampered, it could be because of age, it could be because of mutations, it could be because of genetic factors, it could be because of so many other factors, including chemicals. Then these cells which are mutated further mutate, they increase in number, intensity, and aggressiveness and try forming a ball of cells, which could be a tumor. Further, this ball of cells would go from the organ of origin uh, through the lymph nodes and through the bloodstream to other organs to metastasize. And that is what the cancer actually does. It eats up the nutrition of the host organ as well as the other organs that it invades. So, lung cancer definitely, like any other cancers, has a pathogenesis of chronic inflammation giving rise to abnormal cells and further mutation of the cells.
Thank you so much, sir, for explaining that to us in a very layman's terms so that it becomes very easy for us and to all our audience to understand how exactly it develops at a cellular level and spread. So, another question on this is despite advancements in cancer research, lung cancer remains one of the most prevalent cancers. So, what factors do you believe contribute to its continued high incidence globally?
So there could be various factors. I think it's not just about smoking or chemicals, but it's because of non-smoking etiologies or causes like pollution, dust, chemicals. There are some workplace-related chemical exposure which happens over a period of many years, and this also could give rise to cancers. There is. It is supposed that for passive smoking, also the risk of cancer development is close to 3 times than a non-smoker. So that's how big the risk is. Even people who are working long time in chemical industry tend to develop various cancers, including lung cancers. There is a specific chemical asbestos which is responsible for something called as mesothelioma. It's a type of lung cancer, but it develops into its linings of lung cancer. That's a pleura. And definitely these all things contribute to development of lung and pleural cancers in one way or the other.
Thank you so much sir, for answering that. Moving on to my next question to Dr. Kapil. So, what role does genetics play in susceptibility to lung cancer? And are there any genetic markers that can help predict this risk? So, you're on mute.
So lung cancer, as previously told by the panelists, is mostly associated with the smoking, the air pollution, chemicals, and all those risk factors. Unlike many other cancers like breast cancer and colon cancers, there has not been any definite genetic association or genetic predisposition identified in lung cancer. Although, as the panelists previously said, that we see many of the cases, up to 30 to 40% of cases, we see that are happening in non-smokers as well. And also because many of there is a special subset where the younger children are also affected with lung cancer. So in those subset, there is a possibility that it might be genetically related, but so far we have not been able to deduce any kind of genetic marker which we can use to predict whether individual person is going to get lung cancer or not. So broadly speaking, for this your particular question, so I would say there's no genetic factor is not very important in lung cancer, and there are no genetic markers to where we can test and identify that this person is going to develop lung cancer.
Thank you, sir, for answering that. Moving on to my next question, Dr. Tonse. Ma'am, how significant is the role of early symptoms like persistent cough, chest pain, or shortness of breath in diagnosing lung cancer?
So, by the time symptoms develop in lung cancer, like persistent cough, breathlessness, or sputum with blood in the sputum, or we- noisy breathing, etc. So you are already in stage three. So uh, lung cancer doesn't present very early, like stage one. We virtually do not see unless we detect a screen detected lung cancer. So somebody who is a smoker for past 20 years or so. So we do something called as low dose CT scan in them. So in such patients, you can see a stage one or stage two lung cancer. So otherwise, if somebody smoking, smoker or present or past history of smoking with cough going on for 2 to 3 weeks, which is not resolving, breathlessness on exertion, and there is chest pain, which is localized to one area, especially worsening at night. So these should you the one should seek expert opinion and get a chest x-ray or a CT scan of the thorax to look for underlying cause. So most of the times we see that the lung cancer is already in stage 3 or stage 4 by the time these symptoms set in.
Thank you so much, ma'am, for emphasizing on that. It is very difficult to virtually get, that doubt if the person is having lung cancer or not until unless they have been screened, and that's why we want to highlight the most important part of early detection and screening for lung cancer, or let's say any other cancer, as we spread or do mass screening, or we aware our general public on the screening part. The more screening we get, the early detections, the detection of cancer at an early stage we can get, and there are high chances of getting that treated. So focusing on the early detection and screening, Dr. Tushar, how have recent advancements in screening such as low dose CT scans changed the landscape for early detection of lung cancer?
I think it's what we say as a recommendation now, but widely in the general public, I don't think it's still practiced. It's just like any other screening methodology, unless the people who may get this disease are sensitized towards doing these and they come forward and get tested. The screen detection levels and the number of patients that are detected by screening would be still very low. So it's like mammography for breast cancer that we are doing. Unless the person is interested to get a mammography done and comes forward, it's not going to be possible. So mass level awareness among people, especially who are heavy smokers and who are at a very high risk of development of lung cancer, for them, a low dose CT scan of the thorax at a particular pre-specified interval, and that could probably pick up early lung cancers, which will increase our chances of cure and then also decrease the morbidity and the mortality.
Thank you so much, Dr. Tushar. Thank you for answering that. Moving on to my next question to Dr. Kapil. So, given the high mortality rate of lung cancer, like Dr. Tonsi also said that it gets detected at a very later stage. That is when the symptoms gets visible. It is already at stage 3 or stage 4. So, given the high mortality rate of lung cancer, how effective are the current guidelines for early screening, particularly in high risk population?
So basically, screening guideline, unfortunately, so far for lung cancer have not been very effective in India. So there are particularly two reasons for that. So one is the screening modality, that is HY, which is low dose CT scan, because India, plenty of patients are poor, and affording a low dose CT scan that has to be done every year or even once in 2 years, it is economically not affordable for most of the patient. More important than that is actually the prevalence of tuberculosis, because whenever if you subject certain population to a screening methodology, so all of them will be undergoing CT scans, and many of times a few nodules will be caught up, which may actually be tubercular, and they may be mistaken as early lung cancer, and these population will undergo further invasive testing like biopsy or FNAC to confirm the diagnosis. Also, many of times if we subject every population to low dose CT scan, we may actually catch many false positive cases who are actually tubercular or maybe old tubercular infection, which may be misunderstood, mistaken as being lung cancer, and that creates unnecessary anxiety in the patients, and it creates unnecessary financial burden of undergoing further testing like biopsy and all. So that is why it has not been very effective. The more important thing for me is to sensitization on the physicians level also, that what are the early signs and symptoms of lung cancer. So whenever if you feel that patient is having any shortness of breath, chest pain, or any cough which is not going away after 15 days, so there should be the threshold for getting a CT scan should be low, and the diagnosis and any suspicious the pulmonary nodule, the biopsy should be done. So, and in the high risk population, like the people who are chronic smoker, in those patients only we can counsel for low dose CT scan. For a mass scale, this should not be applied.
Thank you, sir, for answering that. Another question to you is, what are the challenges of implementing nationwide or global lung cancer screening programs, especially in low resource settings?
So as I already explained, the most important challenge is the finances. See, the screening for lung cancer has to be via CT scan. The screening for mammography, screening for breast cancer is actually by mammography, which is sort of an X-ray only. Cervical cancer screening, which is much more common, is actually via Pap smear. Both the Pap smear and mammography are much cheaper compared to CT scan. But still, we have not been able to get even the 3 to 4% of the eligible women to undergo regular Pap screening or the mammography. Forget about getting all the large population for low dose CT scans. So the most important challenge is, of course, the financial reason. Second important challenge is the tuberculosis prevalence, which I already discussed. So because of that, the false positivity rates are very high. So these are the most common challenges. So I think the focus should be on the prevention, to spread a message that do not smoke, and to the air pollution that should be controlled, rather than focusing on the screening for lung cancer.
Thank you, sir, for emphasizing on the basic challenges now, we are facing, so that we can control the lung cancer. But moving on to my next question, Dr. Tonse, ma'am, how can non-invasive biomarkers and liquid biopsies potentially revolutionize early detection and monitoring of lung cancer?
That's a good question, very controversial though. So basically, molecular studies, especially circulating tumor DNA in the blood, it's a non-invasive test. Obviously, you're not putting a needle in the lung and getting a tissue out and looking under the microscope. You're just taking patient's blood sample and trying to look for tumor DNA. That is, after the cell dies, the cancer cell dies, it releases something called as tumor DNA. So you're trying to quantify it and look for analysis whether there is any mutation in those cells, etc. So in colon cancer, so right now it's still like in the nascent stages, or it is sort of coming up as a screening for for colon cancer. But see, here we are talking about prevention. So even in colon cancer, rather than checking a ctDNA, which is very expensive test, a simple colonoscopy would be, I think, better, because here you are able to prevent virtually development of overt colon cancer. If you pick up something called as a polyp, which changes later on its behavior to a dysplastic polyp, that is precancerous lesion, and to invasive colon cancer. That's how you prevent a cancer. But by the time you have a circulating tumor DNA, that means there is already a cancer which is formed in the body. So I think we are still in nascent stages when we talk about ctDNA for cancer detection. But definitely, once we know that there is a malignancy, when we don't get a good piece of biopsy, especially in lung cancer. We do send routinely blood for ctDNA testing and also analyzing the tumor content as well as type of mutation in it, so that we can pick up more and more mutations for which we have targetable drugs available, which improves the survival and reduces the mortality due to this lethal disease.
Thank you, ma'am, for answering that question. Moving on to my next segment, that is prevention and risk factors. Like Dr. Kapil also said, we need to focus more and more on prevention so that we can decrease the number of lung cancer. We have to educate our public more towards the prevention of lung cancer. So, moving on to my first question for this segment is to Dr. Tushar. So, what proportion of lung cancer cases are directly attributable to smoking, and how do we address the ongoing public health challenge of smoking-related cancer risk?
I think even today, 80 to 85% of the patients' cancers could be related to smoking in one way or the other. It could be active smoking, it could be passive smoking. But yes, around 80% would be still related to smoking and related carcinogens. So we all know that tobacco smoke has close to 400 chemicals, out of which 40 are cancer producing, cancer causing carcinogens. And just for the public awareness, I would say the figure goes that if somebody continues to smoke one pack per day for 30 years, then the risk of development of cancer, lung cancer, as compared to a non-smoker, is 50 times higher. If the same continues for 40 years, then the risk is almost 120 times. So that big is the risk associated with prolonged smoking. Even after people quit smoking, the effect of these chemicals remains in the body for the next 15-20 years. So there are so many people who started smoking at the age of maybe 18, have quit at the age of 45, and still developed a cancer, lung cancer at the age of 60. And that's typically the case. The carcinogens cause a lot of chemical phenomena in the body, which gives rise to the development of abnormal cells. And once your immune systems are down because of whatever reasons, you're getting old, the body is not able to clear up the abnormal cells. That is the time these people will start getting these cancers. So I think very important for people to understand it's not just that I've started smoking, I've quit smoking, and still I got cancer. The effect of those carcinogens, those chemicals is going to remain in the body for a huge number of years. Typical case again is about keeping tobacco in the mouth. The chemical is not only in the mouth. From the tip of the mouth to the anus, every cancer can develop for these patients because the chemical moves into the body and causes a lot of chemical phenomena. So these are the things which are associated and very, very important to bear in mind. Of course, coming to the prevention, it's very important to educate these or what we say education about prevention right from the school and college days, because the most of the habits also start there, and then these habits become your lifestyle. They are there your life, and it's very, very difficult to discontinue those habits because of various reasons. There could be a psychological dependence, there could be a physical dependence, and it's like quitting again. The habit is there, it's forming, and quit many times. So I think right from the school and college days, there should be a proper education about what is the risk of these cancers, what are those cancer producing agents, why is it important to lead a healthy lifestyle, so on and so forth. Of course, there could be other reasons like government policies could be there where they could ban at certain places, and if this ban is really properly executed, then these what we say as number of incidents of smoking and related cancers would also go down.
Thank you so much, Dr. Tushar. Like you emphasized on how this smoking has attributed to lung cancer, but I have to talk about the non-smoking related lung cancer, particularly in women and younger population, and what are the environmental factors contributing to this trend?
In for the non-smoking, again, as I said, passive smoking also is very important. People who are not smoking, but their colleagues, their family people are smoking, and they are continuously exposed to these smokes. Workplace related exposure to chemicals is important. Pollution, dust, all these are contributing a big way to development of various illnesses, including cancers. This exposure is of course over a prolonged period of time, which gives rise to the abnormal cells. And if all these also can be attributed or taken into account, a very simple example is chula. And
Hmm.
in villages, women especially do that. And because of the constant exposure to that smoke and that those chemicals associated with those smoke, they are at a very high risk of development of cancer, especially the lung cancer, because it's directly going to your lungs uh, through the windpipe, and that's the where the cancers would commonly develop. So switching on to gas, or see what we say as other modalities, electric modalities, would definitely in the long run help in curbing the incidence of cancer in such rural population where there are a lot of exposure to the smoke related to chulas.
Thank you so much, sir, for actually identifying the reasons why, how we can prevent is whether it is a rural or urban area, both ways. Moving on to my next question to Dr. Kapil, sir, can lifestyle modification like dietary changes or physical activity have a measurable impact on reducing lung cancer risk, even for those with the genetic predispositions?
Absolutely. So one thing, the most important thing that already highlighted by Dr. Tushar is that the prevention of smoking. So either the active smoking, the most important, apart from that, the passive smoking, secondhand smoking, air pollution, particularly in Delhi NCR, and we can have wear mask and put air purifier and all those things. Apart from the lifestyle modification, just keep your weight in check. So maintaining a healthy body mass index, or keeping a weight in check, taking healthy food which is rich in the multivitamins and minerals, high in fiber, low in red meat, and doing some kind of exercise for at least 30 minutes to 45 minutes every day. So these are the things which help not just for lung cancer, for other cancers as well. uh, Although, because as I previously also told that other genetic factors, all these, they do not, no studies so far has measured the amount of impact these lifestyle changes have been can contribute to generation of lung cancer, but is still for overall good health as well as for the other cancers. So these kind of lifestyle modification must be kept.
Thank you so much, sir. My next question is Dr. Tonse. Ma'am, how do air pollution, like Dr. Kapil also explained us, how do air pollution and occupational exposure compare in terms of their impact on lung cancer risk? Especially, like sir also said, people who are living in Delhi NCR or any of the areas where the air quality index is very high and there's so much of pollution.
So yes, we do have a measure which is called as air quality index (AQI), which checks at the breathable, safe level of air. So when you have pollutants in the atmosphere, uh, particularly the particulate matter, smog, and exhaust from the vehicles and from factories, industrial areas, as well as industrial and building constructions, etc. So they increase the particulate matter as well as toxic fumes like sulfur dioxide, carbon monoxide, nitrogen oxide, which are beyond permissible limits. So these chemicals in turn incite inflammatory changes and lead to cancer. So not just smoking, non passive smoking and indoor pollution, as the Patil mentioned, like chula, coal, burning of these fumes, and inhalation of these toxic fumes by women indoor who do not have a very good, robust exhaust facility available in the villages. They are at risk of developing lung cancer. And also occupational exposure like coal mining industry, and people those who are working in asbestos or silicon industry, so they are exposed to asbestosis, silicosis, and such kind of lung inflammatory diseases which are called as interstitial lung diseases, also predisposed to future lung cancer. So there are multiple environmental exposures going on apart from smoking, which are contributing to lung cancer.
You rightly pointed out, ma'am, there are many other factors other than smoking, which are kind of making it more prevalent amongst the people about, for the lung cancer, because I was reading an article in that it was written into 100 times the stubble burning is creating that pollution, into 100 times of that the industrial waste are creating that kind of pollution, the industry
Yes.
waste. So if we
So
people who are
basically,
living,
burning of the crops, especially in the NCR region, which is also contributing to poor air quality index during winter season, apart from the vehicular exhaust or the industrial pollution. Yes, burning of crops, yes, it's a major contributing factor. So there are various measures which is being undertaken by the government, uh, construction industries putting a ban on unassigned or unauthorized constructions, vehicular exhaust, like you have to get a PUC checkup, and also uh, asking industries to have their chemical exhaust under check. So these are the things which government needs to do, and I guess we are there. Probably we need to do more, and we need to educate and take things proactively.
rightly pointed out, ma'am. And I think that's why, because there's so much of industrial waste, industrial pollutions coming out, stubble burning is making a large impact. I think, but that's how the government are implementing their policies to curb all these things, putting a little bit halt or ban on the constructions or of the type of vehicles and every other thing. So I think those are the ways where that's how we can control the pollutions. Other than the smoking habit which people have, I think that's one of the major another major reason of why, because of for the lung cancer. My next question is to Dr. Tushar. So, given that the lung cancer often develops without noticeable symptoms until advanced stages, how can we improve public awareness of risk factors and absence of early warning signs?
Yeah, so I think more important is early warning signs, and there is for in general for cancer there are few warning signs which should come, and the patient should get educated about it. It's not just the patient. Many times we have to also educate the primary caregivers or doctors, general practitioners, because as Dr. Tonse has already pointed out, that by the time the patient comes to us with coughing and blood in the sputum or hoarseness of voice, the disease is already spread to mediastinal lymph nodes, that is stage 3, and it's too late by then because the cure rates are quite less for such stages, and surgery may not be an option. People may have to we have to go for some other procedures like chemo and radiation. So I think that is more important. Any cough which is persistent, associated with little bit of hoarseness of voice, weight loss, blood in the sputum, all these need to be investigated thoroughly. They may or may not be cancer, but they need to be investigated thoroughly, and that is to be borne by the common public. For doctors, also general practitioners, we would say that anything which is lasting for more than 15-20 days, and you feel that it may not be always allergic, or the patient is developing other symptoms, please refer them to higher centers for further investigations. Now, even tier 2 cities have CT scan facilities. And the moment we catch up something on a CT scan, which is far better than an X-ray, would increase our chances of cure for such patients and decrease the cost of treatment also tremendously.
Thank you, sir, for explaining that. Moving on to the next segment, that is treatment options and innovation. We have discussed about the screening methods, the preventions, and now the treatment options and the advanced treatment options, the innovations we all have, so that it's better than the previous generation had. So how we can treat it and help a patient to get rid of this. So my first question is to Dr. Kapil. So, what are the most promising recent advancements in lung cancer treatment, and how do they specifically target different genetic mutation in the disease?
So, lung cancer management, especially in the advanced stage, is undergoing a revolution right now. So, even as we are talking, so we are moving towards something called as precision oncology. So, what is that? Rather than giving exact same treatment to every patient, now we are moving towards customized treatment plan for every patient. How do we decide? So there are things called as immunotherapy, and there are things called as targeted therapy. So these are unique for every patient. So depending upon a particular patient's tumor genetic markers, and there are some tests that we run on the biopsy specimens, then we get to know what kind of mutations or DNA damages this patient is carrying, and depending upon that, there are different kinds of medicines within a umbrella of immunotherapy and targeted therapy which can act. So also there is advances in the area of something called as next generation sequencing. Now we are doing that, and not just with the tissue biopsy, also as previously mentioned in the liquid biopsy, also we can run these tests. And these kind of therapies have actually revolutionized the treatment paradigm. So previously the survival of these patients, which is often used to be less than a year, is now increased to maybe up to 5 years in certain cases. So there are particular mutations like ALK mutation where these patients are living beyond 5 years, and the symptom free quality of life is also improving. But as I already told, this is an area in progress. So every day new researches are coming out. We are in India also, we are doing many researches. So there we are trying to identify exactly what mutation is causing this particular cancer and whether we can target it with a particular medicine. So that is an area, and hopefully within the next few years, as government of India has commanded, so probably we are going to have our own immunotherapy which are made in India. So that is going to give a major push to this kind of technology, and probably in the next coming 5 years we may actually be able to cure or at least control even the stage 4 lung cancer in most of the patients.
I think that is all because of the research, new advancements, innovation that has happened in a decade or more than that, that has helped our people or the medical industry to fight against deadly cancers. So I think that's a great job done by the researchers and the medical industry. So and the doctors also, because continuously they are on their toes to treat their patients, and they try to provide as much as possible help they can. So thank
Absolutely.
you, doctors, for all those things. My question is to Dr. Tonse, ma'am. What are the current role of chemotherapy in lung cancer treatment, particularly with the rise of targeted therapies and immunotherapies?
Okay, chemotherapy is still being widely used in lung cancer, especially after surgery in certain types like stage 2 or 3 lung cancers who require disease control to reduce the chance of recurrence, and also in metastatic disease. In metastatic disease, when you do not have an actionable mutation for which you can give a target therapy medicine, or if a patient cannot afford immunotherapy. In both the scenarios, we do offer routinely chemotherapy to lung cancer patients. So, also in patients, those who have received immunotherapy or target therapy and have exhausted these options, chemotherapy is still being used in the second line or third line settings for them.
Thank you, ma'am, for explaining us the role of chemotherapy and immunotherapy for the treatment process of lung cancer. My next question is Dr. Tushar. Sir, could you elaborate on how personalized medicine is reshaping the lung cancer treatment and how accessible are these treatments for patients in developing countries like ours?
So I think it's made a great stride in terms of what patients get the precise treatment so that they live longer, good quality of life without any major side effects of other treatments. Very classical example here is that 20 years back when we started, we were treating all lung cancer patients with chemotherapy. Then we came to know that over a period of time that certain histologies or types would have to be treated differently. Then by that time, there were mutations which were found. A very common mutation is called epidermal growth factor receptor (EGFR), and if this mutation is present, there are two major types of that. Then a simple tablet can work for many years for these patients. So that tablets also evolved with time. The first tablet gave us close to 8 or 9 months of good survival, after which the drug would stop acting. There was the second generation of medicine which evolved and it gave us 1.5 years. And now there are third and fourth generation of medicines without chemotherapy. I'm talking of the tablets which are without chemotherapy, which are giving us something like 2 or 3 years just with the help of tablets. So things are evolving. Also, because there are many generics which are coming in for most of these tablets now, the patients can easily afford these tablets, take them, and they just need to come for a follow up maybe 3 monthly or 6 monthly with a scan to see if they are responding or not responding. So things are becoming easier, and today close to 45 to 50% of our cancer patients, lung cancer patients especially, can be treated only with the help of some pills or some targeted therapies. They need not always undergo chemotherapy, especially elderly population where we are going to have many problems during giving them chemotherapy, including WBCs, hemoglobin going low, platelets going low, they catching up some infection, so on and so forth. So yes, definitely targeted therapies are making good strides. They are easily available today. Many generics have come up, so people can afford them. And in times to come, even the other therapies like immunotherapies would become what we say affordable to a majority of our class of our cancer patients.
Thank you, Dr. Tushar, for answering that. And you also brought out a point of emotional and psychological support, which is very important during the treatment process. And we'll be talking on that aspect now. So, my question is to Dr. Kapil. So, lung cancer patients often face significant emotional challenges. How should healthcare providers address the psychological well being of the patients from diagnosis through the treatment process?
So, as rightly pointed out, actually, not just lung cancer, any cancer, that diagnosis, as soon as the diagnosis comes out, it's a shock, not just for the patient, but the entire family, the office colleagues, and everyone involved. So, a lot of mental trauma is involved. So, at this is the point of time where, right from then, the treating physician or the oncologist should start addressing the mental health concern also. So it's a multidisciplinary care. We do have psychologists on board with us, so they help in dealing with the emotional trauma associated with it. We also know that the kind of mental health that it's a process through which a patient goes. So initial the stage of shock, finally bargaining, and then realization. Then patient looks for the option, and finally acceptance phase comes when the patient actually accepts the fate, whatever the fate is going to be. So all of that phase, the psychologist is very important. Psychological counseling has to be there. Second important thing is the social support. So if someone, a patient who has family and nearby, so then it provides an emotional comfort to the patient. But sometimes we do have the elderly population who do not have their children living abroad or not nearby, or somebody is with alone. For those patients, it becomes particularly difficult to accept to the new reality. And because it's not just the emotional, because cancer is a financially also it becomes very burdensome, the logistics, because frequent visits to the diagnostic center and the hospital, all of this puts a toll, not on the physical aspect, as well as the mental, financial, and spiritual as well. So it is utmost important that we provide them psychological comfort and counseling, starting from the point of diagnosis itself. So that is how we try to communicate with the patient. And communication is very, very important, not just with the physician, but also the entire team, the nursing staff, the friends, the family, the NGO. There are various NGOs which are doing wonderful jobs. So we provide the medical part, but these NGO, they help in the psychological counseling. Also, we have patient support groups also. So there are hundreds of patients who all have the diagnosis of cancer, who where they form a group and they have monthly or weekly meetings where patients who have defeated cancer, they share their success story. So that kind of motivates this patient, that if this patient did defeated the cancer, I can also do it. So that kind of patient support group. So it's a combination of all those factors which helps us in tackling the mental health issue in these patients.
So you rightly said it. It's more of a teamwork, whether it is doctor, it is a psychologist, or the nurses out there. And the most important part is the communication. The more we communicate, the more we're able to understand the mindset of the patient, right? What he or she is going through, and it will be easier for the team to address their concern points. And I think that's how the team can make them out from that anxiety or the thinking process that's going on.
And also, more important aspect is putting the patient in center. So sometimes we doctor, particularly, become very pushy. Like this is the correct treatment, you have to take this treatment, which actually may not be in alignment with patient's preference because they have some other priorities in life. So communication becomes very, very important. We have to understand what the patient himself wants, what the family wants, what kind of lifestyle he is looking at. We have to understand what kind of lifestyle patient was living prior to the diagnosis, and whether he or she would like to continue living in that direction, or patient wants to go all in that I want to defeat the cancer. So it's a balance that we have to strike out. So putting patient in center and then taking a informed decision, sort of, where it's a team decision. It's not that my decision that you will be getting this medicine. The patient's decision also has to be respected, and that also has to be taken in account. That solves lots of problems.
Rightly said, sir. Moving on to my next question, Dr. Tonse. Ma'am, how can healthcare professionals ensure that the family members and caregivers are adequately supported during the treatment journey of a lung cancer patient?
Yes, apart from the patient's family and friends do feel distress and various other emotions when you disclose about the disease, the seabird, as well as they're worried about the outcomes, the uncertainty period to live with, and to support somebody whom they love, their loved ones through this journey. It's a very quite a difficult task. Um, I think there are various ways. The physicians have to be very communicative with respect to the disease outcomes. So, what to expect, what are the benefits of therapy, what are the side effects of therapy. Also, the financial aspect. They are the ones who dealing with the therapy related costs, etc. So, being upfront and telling them that these are what are the expectations, whether the patient or the relative is paying out of pocket, or do they have financial support, like do they have any insurance, etc., to pay for them. Also, involving a psycho-oncologist when you know that a patient or patient's family is in distress and requires, otherwise also routinely, I think it's a very good practice to involve a psycho-oncologist. And also try and be patient and listen to them. You need not always fill it with words. At times they just want you to listen, and they want to speak it out. You don't have to give any solution all the time. At times listening to them is probably it would help. And also giving them certain ways to cope up, like coping mechanisms like deep breathing exercises, or asking them to get involved with the yoga pranayam exercises, or group therapies, hobbies, so it can reduce something, that term which is called as caregiver burnout. So somebody, the spouse or the family member is repeatedly coming to clinic every weekly, so leaving his or her job. So it also adds on to certain amount of mental distress. So in these people, you need to talk to them, morally support them, alternate talking, not just about the cancer, some other alternate talking, getting them engaged in various other activities would probably help them.
Thank you so much, ma'am, for actually pointing out that it's not just about the patients; it's also about the family and the caregiver, who are always and constantly there with the patients. And if they are motivated, if they feel supported, I believe then only they can pass the same energy to the patient. And it's just that if they feel valued and they feel that the confidence in the treatment process, then they can pass the same energy to the patient. And for this, not just to handle the patient, the caregivers or the family, to handle this everything in a very overall aspect holistically, the medical team, the hospitals, the doctors are doing their great work to handle all such situations collectively. But when it comes to patients counseling, Dr. Tushar, I would like to know, what role do patient counseling and mental health support play in improving the overall outcomes and quality of life for lung cancer patients?
I think counseling is very important because emotionally they are drained. They are at a much negative level than a common man, and counseling will just boost up their morale, keep them up so that they complete the treatment. And counseling is not required only for stage 4 lung cancers. It could be also for stage 1. That diagnosis of cancer itself plays doom in their minds, and they think that the world is over now, I'm going to die. So many times you have to counsel that yours is a very curable cancer. Please go ahead with your treatment plan, treatment, surgery, chemo, radiation, whatever that could be as per the scientific evidence. And that lays in their minds very well. The counseling can be done by the doctor, by a trained psychologist who could be there. The counseling also could be done by fellow patients who have gone through the same feelings and the same treatments earlier on. So there are so many patient advocates who are there right now and who are willing to act as volunteers and counsel the future patients. So we've got close to our own patients who have been treated earlier in the past, who come take rounds regularly into the hospital and counsel all our patients to complete their treatment to get the best results. So all kinds of counseling could be done by the doctors, the relatives, the psychologists, as well as the previous patients. That's very, very important. The previous patients is more important because they can share their thoughts and feelings with these patients. They can tell what they've gone through, how they have coped up with the situation emotionally, financially, and socially. And it's the wonderful example that they set for the patients so that they can take that path.
Thank you so much, sir. Moving on to our last segment, that is the post-treatment and care and survivorship. Like Dr. Tushar said, it is very important. If we have that small meetings with the patients who have the survivors, the cancer survivors, so that they can cheer up the other patients. So I think that way, if those meetings or those regular checkups can happen, that will play for that that can help in two direction. One, it can help in the regular meetings with the patients, the current patients, and the regular checkups for the cancer survivors. So my question to Dr. Kapil is, how crucial is this long term surveillance in detecting recurrence, and what are the best practices for monitoring the lung cancers in the survivors?
So absolutely, it is extremely important. Can never be overemphasized. So the thing is that even in early stage lung cancer, which has been cured via surgery or via radiation, via chemotherapy, everything has been finished. So there are still definite chances that cancer may recur after a few months or after a few years. So there's a surveillance protocol that we follow according to the stage of the disease. So which involves regular OPD visits, sometimes every 3 months, then we increase for a few years, then we increase it to every 6 months for a couple of years. Then after once the 5 years have elapsed, then we make it once a year, in which we do regular general physical examination that we perform on the patient, that may be coupled with some blood test that we offer. And also at least initially year once in 6 months, or maybe later in once a year, we also do some scans like CT scan or PET scan to detect if there are any uh, recurrence of the cancer is there or not. So that kind of occurrence is very, very important, so that if it happens, so we catch it up at the early sign as soon as it presents. Another important thing these days that is coming is the circulating tumor cells. So that is a newer technique that is coming up. So in which we are able to, that is a simple blood test like liquid biopsy only, sort of liquid biopsy. So that we regular blood test also we can do. So that tells us about the possibility of recurrence very well in advance, even before it appears on PET scan or CT scan. So, but it is an evolving area. It's a field of research. Lots of research is going on. So, yeah, we do not do it routinely for all the patient, but that is certainly that we will start doing in next couple of years. So as of now, the message is that if you have been treated with lung cancer, you are completely cured. So as your oncologist has advised the follow-up visits, that maybe after 3 months, after 6 months, or whatever time they have advised. So please go for them. Whatever test you have been advised, please do that, because there are chances that your cancer might be there. So regular follow-up visits will help us catching those when it has not, spread in entire body.
Thank you, Dr. Kapil, for highlighting all those points, which is very important for the post-treatment process, and how this long-term surveillance can help in detecting reoccurrence of the lung cancer. Moving on to my next question is Dr. Tonse. Ma'am, what role do multidisciplinary care teams, for example, oncologist, pulmonologist, and psychologist, play in managing post-treatment lung cancer care?
So, multidisciplinary team involves post therapy, requires monitoring for disease recurrence, as well as somebody who's a smoker, nicotine de addiction, etc. So, to prevent developing a second malignancy or other diseases due to tobacco smoking. So screening obviously is done by the caregivers in the form of a CT scan, surveillance, that is surveillance CT scans every 6 months for the first 2 years, followed by and then thereafter every year for the first 5 years. So because the increased risk of recurrence is in the first 2 years, and then it starts dropping as the years advance. So apart from that, even psychologists to deal with the post-treatment complications like uh, peripheral neuropathy, alopecia, multiple things, side effects. So one can provide psychological support to these patients, and de-addiction support programs also are very useful. So
Thank you, ma'am, for answering that. How all the doctors in the team can help the patients for even after their post treatment. My last question is Dr. Tushar, sir. How can we address the healthcare disparities faced by lung cancer survivors, especially in terms of access to ongoing care and rehab in remote areas? So,
I think a lot of it depends on the government policies. Now the government is trying to make up various cancer centers, including all the facilities, even in tier 2, tier 3 cities, and that's the aim of the government. In the coming years, because the incidence of cancer also is going to rise. Even this year, we have seen 15 lakh new cases of cancer. If we what we say as analyze, and in the coming 10 years, this figure is going to swell to 25 and 28 lakh per year new cancer cases. And hence, the government is understanding this and probably coming up with newer centers with all the ultra tech, ultra modern facilities, including the treatment part, prevention part, the screening modalities, counseling part. If this is undertaken, then a huge burden of cancer can be shared, it can be decreased, and the ultimate aim of cancer doctors or cancer physicians or surgeons is now to make the cancer, even the last stage cancer, a chronic disease, just like a diabetes or blood pressure, where we will not probably able to cure it, but control it to a great extent for a great length of time with some of the other medicine. And there will be times where multiple medicines will be used. There will be times where a single medicine will be used. There will be times when chemotherapy will be used. And there will be times when only targeted oral therapies will be used. So there, this time or this day is not far when cancer will become just like a diabetes or hypertension, which can be controlled with various medicines or that are available to us.
thank you, sir, for highlighting all those important points and contributing to this greater vision to create awareness on lung cancer awareness. I would like to thank all my panelists for this, for coming to this platform, taking out time out of the busy schedule and spreading this awareness amongst the general public. As we know, the lifestyle habits has drastically changed. We had adopted more of the Western culture, and the air we breathe is comes under the category of poor, very poor, or hazardous most of the times, which can, even for a non-smoker, can create a situation of cancer which no one is looking forward to. And like Dr. Tonse also said, it is very difficult to detect cancer at a very early stage visually until unless the screening is done. So once the symptoms get visible, it has already reached to a very later stage. So I think that's the most dangerous part of this lung cancer as compared to any other cancer, right? And no one wants to be in that situation. But thank you to all the doctors, to all the panelists who are present here, who deal with all this situation every day, make all their best efforts to treat their patients so that they can see them smiling, happy, and back in their normal life again. So thank you so much for becoming one of the voices to spread this awareness, because your insights and expertise matters a lot to create this general awareness. Thanks a lot to all the speakers.
Thank you. Thank you.
Thank
thank
you.
you,
Thank
Thank you.
Simran, for a very warm moderation. And I thank Pfizer for this wonderful platform to create awareness about lung cancer. Thank you, my fellow panelist, Dr. Tushar Patil, and sir. Thank
Thank you. Same
Thank
here.
you.
Good
Thank
night.
you, everyone.
Good night.
Good night.
you. Thank you.